Welcome to the series where I review the 2025 ACE Consensus Statement on the algorithm for the management of adults with dyslipidemia. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today we will discuss management of dyslipidemia in special populations. Older adults represent the highest risk group for cardiovascular disease related to atherosclerosis. More than 80% of cardiovascular deaths occur in individuals 65 years of age and older, who face substantially elevated risks of recurrent myocardial infarction, stroke, and mortality. Importantly, the strongest evidence for cholesterol-lowering benefits in older adults comes from secondary prevention studies. Large, randomized, controlled trials clearly demonstrate significant reductions in all-cause mortality and major coronary heart disease events with statin therapy in this age group. When we look at primary prevention, several trials show significant reductions in ASCVD events in individuals 65 years of age and older. However, once we move beyond age 75, the data become limited, particularly in individuals without diabetes. That uncertainty becomes central to decision-making. As a result, statin therapy in older adults must involve shared decision-making with careful consideration of polypharmacy, frailty, comorbidities, competing risks, life expectancy, and side effects. A common concern is statin-associated muscle symptoms. Importantly, muscle-related side effects do not appear to be more common in older adults at higher doses. That said, when muscle symptoms do occur, practical strategies such as dose reduction, switching statin agents, or interval dosing may be effective. Drug-drug interactions matter greatly in this population. Pravastatin or rosuvastatin are preferred. For older adults with established ASCVD or at increased ASCVD risk who do not reach LDL-C goals on statins alone, ezetimibe and PCSK9 inhibitors may be added. However, it's important to acknowledge that data on the safety and efficacy of these agents in older adults remain limited. Finally, evidence guiding ASCVD prevention in elderly individuals with hypertriglyceridemia is sparse. In these cases, clinicians should follow available adult evidence-based guidelines, recognizing the absence of age-specific data. Next, let's turn to adults receiving gender-affirming care. Hormone replacement therapy may cause small changes in lipid levels, but there are no prospective high-quality studies demonstrating that these changes translate into increased ASCVD events. Risk assessment must be nuanced. High-risk behaviors, particularly tobacco use, may significantly increase ASCVD risk. It's also important to recognize overlapping risks. In 2022, transgender individuals accounted for 2% of new HIV diagnoses, with transgender women representing the majority. HIV itself increases ASCVD risk, which may justify higher rates of statin use in transgender women. When estimating ASCVD risk in individuals receiving gender-affirming hormone therapy, clinicians may calculate risk using both sex assigned at birth and self-identified gender, then use the higher estimated risk to guide shared decision-making around pharmacologic therapy. Now let's discuss adults living with HIV. Adults with HIV should receive lifestyle counseling, including smoking cessation. In patients less than 40 years old, primary prevention decisions should be individualized. Pitavastatin is preferred in people with HIV at low to moderate cardiovascular risk, as it reduces ASCVD events and avoids ART interactions via glucuronidation. Rosuvastatin, equal or less than 10 milligram per day, is an acceptable alternative, and atorvastatin, equal or less than 10 to 20 milligram per day, can be used with select ART regimens. And in my board review course, we have a bunch of mnemonics addressing the different statins, and the mnemonic I had for this was RAP, R-A-P, Rasuva, Atorva, PETA. Pravastatin should be avoided with darunavir, but is otherwise safe. No simvastatin, no lovastatin. Simvastatin and lovastatin are contraindicated with protease inhibitors or cobicistat. Rosuvastatin, 20 mg per day, is a high-intensity option with relatively low interaction risk. If LDL goals are not achieved or statins are not tolerated, ezetimibe, bempedoic acid, PCSK9 inhibitors may be added. This is what AACE is saying: ezetimibe, PCSK9, bempedoic acid. In patients with HIV and hypertriglyceridemia, prescription omega-3 fatty acids or a fibrate may be used, as these do not interact adversely with ART. Just do not use gemfibrozil. Now let's discuss chronic inflammatory and autoimmune diseases. Chronic inflammatory and autoimmune disease should be treated as a risk-enhancing factor for cardiovascular disease. Patients with psoriatic arthritis, rheumatoid arthritis, SLE, and inflammatory myopathies warrant careful risk assessment, as chronic inflammation independently increases cardiovascular risk. Patients with psoriasis and rheumatoid arthritis should be considered higher risk regardless of disease severity. Now, what's the evidence for statin therapy? In rheumatoid arthritis, statins significantly reduce all-cause mortality. Statins slow progression of atherosclerosis. In SLE, it's not so clear. In SLE, large prospective statin trials are lacking, and smaller studies did not show benefit of progression of subclinical atherosclerosis. Psoriasis, secondary prevention trials show similar cardiovascular event reduction with statins in individuals with and without psoriasis. And then in meta-analysis across autoimmune diseases in SLE, rheumatoid arthritis, type 1 diabetes, statin use for primary prevention is associated with lower mortality and cardiovascular events. So what should the clinical approach be? Primary prevention, an aggressive strategy combining lifestyle modification and statin therapy is advisable due to heightened cardiovascular risk and generally low side effect profile of statins. Now, about statin intolerance or immune myopathies in this population, moderate to high-intensity statins may be tolerated in selected individuals, and PCSK9 inhibitors can be considered first-line therapy in symptomatic or statin-intolerant patients. Now let's talk about adult survivors of childhood cancer. Adult survivors of childhood cancer, particularly those treated for acute leukemia with total body irradiation and stem cell transplantation, are at high risk for dyslipidemia, type 2 diabetes, and osteoporosis. The typical lipid pattern is low HDL with high triglycerides, likely driven by sarcopenia and lipodystrophy. DEXA can quantify lean mass, fat distribution, sarcopenia, and bone density. Physical activity improves metabolic risk factors but does not reverse abnormal fat distribution. Despite limited cardiovascular outcome data, the clustering of risk factors and evidence of accelerated aging support a low threshold for lipid-lowering therapy with attention to short stature and low lean mass when dosing statins. Now let's discuss adults who have undergone solid organ transplantation. Adults who have undergone solid organ transplantation have a high prevalence of dyslipidemia and increased cardiovascular risk. Lifestyle counseling and pharmacologic therapy are indicated, with attention to secondary causes and drug interactions. Statins interact with immunosuppressive agents such as cyclosporin and tacrolimus, and fibrates should be used cautiously with cyclosporin. Trials after kidney and heart transplantation suggest modest reductions in cardiovascular events and all-cause mortality with statins, without consistent effects on renal function or cardiac myopathy. Data on PCSK9 after transplantation are limited, but suggest stable coronary plaque after heart transplantation and no impact on immunosuppressant drug levels after kidney transplantation. However, remember, statins should remain first-line therapy. In summary, dyslipidemia management in special populations requires individualized risk assessment rather than a one-size-fits-all approach. Many of these groups carry risk that traditional calculators underestimate, making shared decision-making, attention to drug interactions, and thoughtful statin selection essential. Statins remain first-line therapy across most populations, with non-statin agents used selectively when goals aren't met or intolerance occurs. Ultimately, recognizing risk-enhancing conditions and tailoring therapy is key to reducing cardiovascular events in these complex patients. And we did it. We reviewed the 2025 ACE consensus statement on the algorithm for the management of adults with dyslipidemia. This podcast, as always, was brought to you by Easy Endo Prep, your foundation for mastering the theory portion of the ABIM endocrinology boards. Easy Endo Prep is also useful for LKA and real-world clinic practice, helping you strengthen your core clinical reasoning. Visit www.easyendoprep.com to claim your free trial. Next week, I will start my review on the 2025 ACE consensus statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. Let's work through that document, one bite at a time.